Good evening and welcome. I'm Dr. Sridhar here, and I have with me a very special guest, Dr. Srinivas Murki. He probably doesn't need introduction for those of you in India. He's a renowned neonatologist. He trained in JIPMER and PGI as well, and we trained together around the same time. We will have a small chat about that as well. Uh, in terms of the work he has done in neonatology, obviously he's a pioneer in spreading CPAP along with other colleagues in India, making the awareness. And now he is an innovator as well. He has his own CPAP ventilator, which we will discuss today as well. So, welcome, Srinivas, and thank you for sparing the time.
Hi, hi. Thank you.
So,
Thank you for inviting and thank you for getting me into this discussion.
thank you. I mean, it's pending for a long time. I mean, you and I are involved in the ventilation course, and I've been meaning to do this for a long time. Uh, Going back to the history, I mean, Srinivas was, I think, 2 years junior to me, and he came as my intern in JIPMER when I was doing my post graduation. He was a very bright, quirky intern. He asks all the difficult questions for a first or second year PG to answer, and very enthusiastic. Obviously, thinks out of the box. And he went on to join his post graduation in PGI when I was my final year MD in JIPMER. So when I went to DM, join my DM in PGI, he was my uh, mentor, so to speak, to introduce me to buffer the shock that the PGI system gives you. So I stayed with him when I joined PGI, and we had curd rice together with nice pickle that he used to make. I got the real introduction to how the PGI junior resident system works because he had like 2 weeks continuous. He was doing neonatology as part of his postgraduate training when I joined, and it was a very rigorous routine. You used to do 2 weeks of day and 2 weeks of night, 12-hour shifts continuously. And he was doing his thesis at the same time. So once he comes back from his night duty, he sleeps for a couple of hours and runs off to see his guide and also to process the information. I mean, he was quite a good student and very innovative. I think you can tell me about your PG days and your DM days. I think you started your DM when I was leaving PGI, but yeah, go ahead.
Yeah, I think the memories are very clear. I think JIPMER days are also very useful and important because I think the learning started from JIPMER because JIPMER is a wonderful MBBS
Yes, Tirumurugan
uh,
and
place. So, yeah. So I don't think you have so much of opportunity to learn anywhere in the world.
yes,
Had excellent teachers, excellent
foundation.
material. So, and spontaneous learning. And in pediatrics, I think was the best because you had a side lab.
Mm.
I know the thrill we used to have looking at the ova and cyst of stools.
And malaria parasite.
Yeah, malaria parasites and
Lumbar
also,
puncture. I mean, we used to get pus in the CSF and teeming with
yeah.
bacteria. I mean, luckily we don't
So
see those anymore. But as you said, the stress on foundation, the basics was very strong. All the
I
JIPMER
remember the
undergraduates.
days when we used to work in intern as an intern and come to pediatric side lab and do a smear to look at cancer cells. So, and you diagnose a case of cancer in
Leukemia.
just in an hour, your thrill is
Mm.
tremendous. I mean, that learning and that thought of a course, I
And you
don't
were the
think.
type who would read up the immediately. I mean, you had the Nelson in the ward and read up
I think
immediately and
the
discuss immediately with all of us as well. Yeah.
I think we were fortunate to have good teachers, good SRs.
Mm.
I mean, it was more like a teamwork, and JR had his own role, and SR had their roles. So I'm sure the things were different, or they're still the same. But for us, it is memorable events.
And
So
in
I think
PGI,
from there, choosing pediatrics was very important. Those days, pediatrics was the choice for most people.
yes.
And if you're a topper, you would have chosen pediatrics, obviously.
Radiology and
I don't
pediatrics
know.
were the top choices. Yeah.
So I don't know whether it was a love for pediatrics or it is that spirit of competition which had made us feel that "Okay, this is the branch we should
Mm.
work for." So I was fortunate to get into PGI. And obviously, while I was doing PGI, you joined as a SR again in DM neonatology.
Yeah.
I think you had a 2 years course.
3 years, 3 years.
So 3 years. Okay. I think
Akhil and
yours was the
Rajesh
first.
was the first batch was 3 years. I joined six
Okay.
months after them. So
Oh, okay. So I think before that it was 2 years, but I think with your batch it became 3 years. And yeah, people like you again inspired us for coming to neonatology.
Mm.
So, and I still remember the days we spent together, as you said, 15 days. I
Yeah,
think looking back, it looks very strenuous, but I don't think we would have felt the stress then. So, in fact, everything was learnable, enjoyable.
you were a
I think.
workaholic. I've seen junior residents crying.
No,
So,
I think it all depends upon how we take it.
yeah,
So, even in the worst of situations, if you start enjoying work, no, then things will become very simple. So I think that was the motto PGI teaches us,
yeah,
because if in work, if you enjoy, time will be time will not matter.
yes,
As you said, my thesis was on connectors.
yes.
So obviously these babies come mostly in the nights.
And Praveen sir
So
was your guide and my guide as well. Yeah.
yeah, so I think connectors and jaundice babies coming late night, they will give me a call. I had to run to the emergency to collect the samples. And because you have to collect a sample before the exchange transfusion is
Treatment. Yeah,
done, so you don't have much time. But I think I never felt the stress. I felt it was just part of the job, and then that's why I think we are here today.
exactly. I mean, the rigor of training in PGI and the grilling we used to get in the morning rounds. I mean, you were a DM student. Which year did you join the DM?
I joined DM in 2001,
So
Jan.
when I was finishing, you were there for six
Yes.
months. Yeah. I mean, Amchu, Naveen came and then you and Gurudat, I think, right?
After Amchu Naveen, Sandesh was there for 6 months.
Mm.
So then I joined after Sandesh.
Yes.
So for 6 months, I worked in pediatric as an SR,
Mm.
thinking whether I should take up neonatology or pediatric intensive care. So, because I was thinking pediatric intensive care is more challenging,
Yes.
more diagnostic dilemmas. So, but somehow I think those days there was no DM in pediatric intensive care.
Yes.
I was uh,
I
I switched from pediatric intensive to care neonatology.
think you made the
So
good choice. It
I had to
suits you well
decide.
to be a neonatologist and you're doing a great job. I mean, coming back to
Lucky.
the current days, I think, I mean, what most people would remember is your role in publications. You have been a publishing machine, so to speak, almost every aspect of mostly respiratory care, right? I mean,
I
sepsis.
think see what I've done is I was very fortunate to be in the right place at the right time. So when I came to Hyderabad, my motto was very simple. So practice is not alone for me. I wanted to join academic institutes. So, but when I came, I joined Nilafar. I worked there for 2.5 years on a contract job. But I realized that in government, to get a permanent job is not that easy. So luckily, then I had to switch from Nilafar to Fernandez Hospital. I worked there for 9 years. So there, I developed the system of DRNB and fellowship in neonatology. So when you have the students coming to you, they're very passionate. They're very hardworking. So each student used to work for making some research. So what I did was I choose subject very carefully, because when I came to Hyderabad, I realized what are the problems. So the problems were mostly related to that at that time respiratory care, and those days CPAP was just starting. So once I came from, if you remember in PGI, we used to use CPAP.
Yes.
We used to do CPAP, but it used to be with a
Mm.
nasopharyngeal, the endotracheal tube put into the nose and cut it and
Mm.
then put it as a single
Yes.
nasopharyngeal tube or 82 put into the nasopharynx.
Yes.
That's how we started CPAP. Then there was some workshop in PGI, and then where we have even shown them how to use indigenous CPAP.
Yeah.
So where
The
you
bike
take the
connector, the
oxygen,
water
you
bottle,
use
and
the nasal cannula to one end of the nasal cannula, you connect the oxygen, the other end put it in the bottle of water.
yeah.
So you knew that okay, this gives pressure. Now when I came to Hyderabad, we were fortunate because when I came to Hyderabad, we had good CPAP machines.
Yes.
So, but the problems were two prong. One is the interface then was still, when I first landed up in Hyderabad, it was still nasopharyngeal. Then luckily, we had Dr. Woong came to Hyderabad once in, I think somewhere in 2004 or end of four. He
Mm.
was in Hyderabad and he showed us the Hudson prongs. So that is when we realized that, okay, this prongs looked much better than nasopharyngeal. Before that, AIMS used to use RGL prongs.
Yes.
So, but RGL prongs can be reused. But between these two, I felt Hudson prongs are very good.
More
So
stable.
we started using them, and then we found very good results. But those days were the days, I think it was in 2004 and 5 and 6 times, when Hudson prong came into practice, and then CPAP almost became a routine in the neonatal care. Then I realized that our failure rates were very high. So we were at 30% failure rates. Most of our babies are between 28 to 34 weeks.
Yes.
So we wanted to know what we can do. And those days, I think the FiO2 criteria was not very clear. If you remember, the first criteria used to be A by A ratio.
Yeah.
A small a by capital A by ratio.
Yeah.
0.2 was the cutoff, and then if your A by A ratio is less than 0.21, you give surfactant. So that was not FiO2 then. So then there were two trials, Werder and Werder trial was there, which was saying that, okay, you give CPAP and surfactant early, then you will be able to decrease the chance of ventilation failure.
Yes.
So that is where my actual journey of CPAP started. So then with the first trial, took the help of my mentors, Dr. Diorari and Praveen sir, for even thinking of this trial, Deepak. So we made the trial protocol, and then we got discussed with them. We made the protocol foolproof, and then we even published in the CTRI protocol. And then we started our first randomized control trial, where we compared 30 versus 50% FiO2. So when we did this, the results were dramatic. For us, dramatic because the need for ventilation came down by 50%.
Yes.
From 30%, we came down to 15%. So when seeing these results, after that, it was becoming a more of an easy job, because now I realized that this is the area where we need to work on.
Yes.
So initially we started Hudson prongs, then these surfactant we started giving early at 30% FiO2. And we were using mostly bubble CPAP.
And surfactant started getting readily available around that time, right?
Yeah, I think when we were at PGI, it was coming around 25,000 rupees.
Yeah.
So it was smuggled from UAE and other countries. But when I came to Hyderabad, ExoSurf was the first one which was available, which was a synthetic surfactant. But later on, I think somewhere in 5 and 6, I think we already had Servanta coming. So the bovine surfactant was available in Hyderabad. So then surfactant became very easily available. Our outcome started improving. We started using more CPAP and more surfactant. Then this wave of CPAP came in, where Woong came to Hyderabad, and then he did a lot of workshops. Then simultaneously, the PGI, AIMS group and ourselves, we got together, and we started doing the CPAP workshop across the country. So the first states which we chose were Telangana, then it was Andhra Pradesh and Gujarat. There are a lot of workshops in Gujarat and
before
Andhra
the IAP and NF fellowship started, no?
Yeah, it was way before that, 2008, 6 to 8 or 9 time. We did so many workshops, and everywhere we go, we will show how to do CPAP, how to use Hudson prongs, how do we give early surfactant. Then while we are doing this, I realized that yes, there is a need for more work on this. So after this CPAP, this surfactant, there was some studies which are saying flow driver CPAP is good. If you remember, there were good studies, animal studies showing work of breathing will be lesser with flow driver. So then we thought Phoenix came out with a flow driver machine. So it is little variant from flow driver, but it has something like pressures are driven by flow. So then we did another RCT comparing bubble versus flow driver. When we did this, we didn't find so much of difference. In the clinical difference was not there. In fact, we felt bubble is easier and cheaper and more cost effective. So we switched over to bubble. So whatever we were doing, we were implementing. So we thought, okay, this is our thing. After that, no flow driver, only bubble CPAP.
Yeah.
Then came the time when we really wanted to see whether, apart from flow driver CPAP, when CPAP is useful other conditions. Because there was a strong resistance that CPAP should not be used for meconium aspiration.
Yes.
So because people felt that lungs are already hyperinflated, so use CPAP, you'll get pneumothorax.
Fighting and so on. Yeah.
Yeah. So, but we felt that why do the babies become hyperinflated? It is ball wall mechanism.
So interestingly, when I was in UK, we used to have this discussion, and I used to start them on CPAP, but my colleague said there is no evidence base. So I remember that your studies were one of the first studies for meconium aspiration, I think.
So then I felt that no, we worked on this, and we realized that babies are doing quite good on CPAP.
Yeah.
So we did first an observation studies, and then so that there is no problem. Actually, pneumothorax was never a problem. So, and I felt that it was actually, if you see MAS, if you give CPAP, if there is RDS, it gets resolved. If there is a ball wall, in fact, the airways are going to be wider.
Yeah.
So it will help hyperinflation.
Exactly.
So then we said that don't worry,
And
start giving CPAP.
PPHN becomes less because you're improving the oxygenation.
Yes. So a MACE improves, PPHN increase, and we started doing this very early in the labor room, from the labor room only. So then you start early, we found that the rates of ventilation came down, PPHN came down, and we published this wonderful article in JAMA.
Yeah.
So, and we said that CPAP is the therapy for MACE. And later you see that how people started using CPAP for meconium aspiration across the globe now.
Yeah.
So then, obviously, along with this came, then Rams Canala came into picture. So when Rams came, then it was a sea change. Well, it's logistically very simple, especially in our country where whether it's Hudson prong, whether it's dragger mask, whether it is something else. No, the problem is fixation.
Training the
So
nurses and the problems. Yeah.
training nurses, lot of humidification issues, the prongs comes out. So then we thought that, okay, this looks something very interesting. So we worked on that again. We started a triple comparator arm, bubble Rams cannula with Hudson prong with this. And we found that Rams is as good as others.
Yeah.
But only thing is with Rams, after we finished the study, we made we made a mistake. What was that? That when you give Rams, in the study we used duodenum.
The leak was
So
reduced.
we totally occluded the nostrils. But after we finished the trial, there was one baby who had a rupture of the stomach. So this is after we finished the trial. We didn't have this problem while the trial was there.
Yeah.
So there will be one baby who will have a problem. Then we realized that, oh, this is something which we have not
Focused
thought
on
of.
it. Yeah.
So then I realized that, no, if you give Rams, you have to have some leak around the nostrils.
Yeah.
So that's why we never occlude the nostrils. And then Rams became part of a routine care for CPAP, NIV. Now you think of nasal HFOV. Everywhere Rams is being used.
Yeah.
And we find it very useful. Although for less than 1 kg baby, when the pressure delivery has to be very accurate and you have to give very high pressures, sometimes we switch over to mass. I feel it was a very good method of
For
giving.
the extreme preterms, we found that as well. Soon after extubation, we go with the mask or prongs, and but Professor Ramanathan uses very high pressures on NIPP. He goes to 30, 34.
I think that's what we came out with the answer that if you're using RAM, you have to use slightly higher pressures.
Higher pressures, yeah.
Because there's a lot of resistance in the RAM scanner. A lot of pressure will be lost there.
Just how to
So if you want to give 6, you have to give 7.
Yeah.
So your set should be always more than what you want to deliver.
When we say the ventilator is compensating for the leak, that's what it's doing. So here, for the resistance, we are increasing.
Yes.
When we don't see it, we are hiding it. But in terms of your innovation, I mean, I think when you spread CPAP all over the country, one of the problems was the lack of blenders in many units because blenders are expensive. And then we started seeing a rise in ROP in the near-term babies where CPAP was being used with 100% oxygen. So I think that's one of the key drivers for you to innovate, right?
So yeah, so what happened is there is mushrooming of SNCUs across the country. Now today we have around more than 1,000 SNCUs in the country.
All these SNCUs, I mean, special care baby units, right?
Yeah, special care neonatal units. So these started mushrooming, and then the quality of care improved. Babies started surviving. But what unfortunately was happening is every baby was getting good oxygen, and babies on CPAP. Although there's a lot of equipment started coming into the market. So, but actually what happens is the compressor doesn't work.
Yeah.
For some reason, if the compressor doesn't work, they end up giving 100% oxygen.
Yeah.
So this made us believe that we need something which has inbuilt compressor. We need to titrate FiO2. Even if you're giving oxygen, whether you're giving TPs, and again, very important in India, all the TPs don't have an inbuilt blender or inbuilt compressor.
Yes.
If you have to use a TPs, you need to have a centralized oxygen, centralized air, and a blender, and which is almost 3 times the cost of a normal.
Hardly anyone has it, so something to cover a labor room.
Yeah, so it's almost extreme preterm babies from delivery to coming to the NICU. You're using 100% oxygen.
Yeah.
So there was a need, and even in the best of the setups, you needed some TPs which has inbuilt blender and FiO2 titration. Then transport, definitely you need something like that. And obviously in the NICUs, if your compressor is not working, then obviously the centralized compressors are not easy to get repair. So it is very costly affair. And most of the hospitals, once the budget goes more than 1 lakh, it goes for 6.
Yeah.
So it's very difficult to get them repaired. And so you needed something which is small, which is easy to
Reliable.
use. So
Yeah.
from looking at that angle, then I worked for almost 5 years. So I got a fish tank compressor initially. Then I did a model. I realized that okay, it works. So then I started realizing that it doesn't give you much pressure and flows.
Who was giving
So
you the
then
biomedical backup? Which company was it?
no, nobody. I was doing all myself.
Oh.
Uh, I'll sit in the NICU, make this readjust. Then I realized that China makes a lot of good compressors. So I imported some compressors from China. So then use my biomedical people to make it functional. So, and I could make a model like compressed air source, compressed oxygen. Oxygen is anyway available. And you have a Y. So when you connect the air and oxygen flow, airflow, oxygen flow,
Like the
you
Venturi
do this
system.
mathematical calculation and you can find the FO2. Now, meanwhile, what happened is while I was
You
doing
have a
this, I
Venturi
realized
system in it, or this
no,
mix?
no, it is just a Y.
Okay.
So because you can use it with only air, you can use it with oxygen
And
or
you
blend.
don't have a measure for it, or you have a FiO2 monitor?
We have a FO2 monitor. So that's where the challenge came in. First, initially it was air oxygen. I realized that obviously this is easy. So,
Yeah.
but it is mathematically you have to calculate it.
Yeah.
So then came this, if you know the ultrasonic FiO2 monitors.
Yeah.
So they were available, not in India, but they were available outside. So we imported ultrasonic FiO2 monitors.
I think the Vayu
And,
system in US they were using it, right?
yes, Texas devices. No, so some of the ventilators now have ultrasonic FiO2 monitors. So what we did was we use a compressor from China. We got ultrasonic FiO2 monitor, and then we mixed air and oxygen. We displayed the FiO2. So you want to increase the FiO2, you just increase the input oxygen. So
Yes.
that's how we made a device,
And
and it
it can
is
be either a wall oxygen or the cylinder.
cylinder oxygen or wall oxygen, but it cannot be directly connected to the high pressure source. If you're using wall oxygen, you have to use an oxygen jar. To
Like
that,
to
you have to
connect
connect.
the neopuffin. Yeah.
Yeah, so TPs like that.
In terms
So
of
then we realized that
the actual marketing, when did you start? 2 years now?
so it's almost like 1 year now.
1
So
year.
before that, it was I had to have this company coming up, and then
I think.
I had to do this with a company which is a startup in Gujarat. So they do the marketing, they do the production and all.
Can you
So I
show
gave
the
my
video you had about it to understand better?
yeah, I'll just show you some of the use case scenarios of this machine. So, so this is the baby on CPAP on Murk's TPs. So you can see that this baby is on a Ram's cannula, and you can see baby is unsupported on CPAP. So
Looks very comfortable.
yeah, so he was a settling baby. So you can see that humidifier connected, and so the input for the humidifier is coming from the Murk's device. You have
Yes.
a flow meter, you have input coming to the humidifier.
Inspirator.
And like other bubble CPAP, we have a bubble jar or a
Circuit is the
pressure
same as
unit.
bubble CPAP, or?
Yeah, any circuit you can use, any bubble CPAP circuit.
Okay.
So what the device has is now, if you look at the device, it has a
Similar to the bubble CPAP.
yeah. So now if you look at this device here, so you have a pressure manometer,
Yes.
measures the exact pressure going to the baby. You have an FiO2 which is delivered to the baby, and you have a flow meter. So you titrate the flow here, and you want to increase the pressure, you put the bubble jar, the tube inside, and you want to increase FiO2, then you need to increase on the input oxygen, which I'll show you in the subsequent slide how to.
You also have a table given to the users, or like how much, what
Yeah,
proportion?
this comes with a device. The device comes with a good table. So this video shows how to increase the FiO2.
Does it have
So
any alarms, leak alarm or anything?
no, actually, I didn't want to make it very complicated because we
Cost.
thought it would be, yeah, but it doesn't deliver pressure more than 25. It was so if you want to increase, you improve the, so you are connecting the oxygen to the bubble jar, oxygen jar, and it is connected to the input is in behind. When you increase oxygen, FiO2 rises.
And if you're using 100% oxygen, you need like 10 liters, or what level of flow do you need?
No, so many times you don't even need that much.
Okay.
So you can see here, no? So you can just give 1 liter or 1 liter of oxygen, you're able to give 40% FiO2. You decrease oxygen a little more, you will see that FiO2 is falling down.
You
So there is
measured
a
the pressure in the nasopharynx or anything like that, that the Australian studies are
yes,
doing?
we did measure and then we calibrated to see that whether it's working. But it's very simple, isn't it? This is display and you have a bubble jar showing the pressure there. So obviously nothing can be better than the bubble jar pressure display.
Yes.
So this is the digital display and you have the bubble jar display there.
It's the
So
same as the indigenous CPAP that we use and the bubble CPAP. So it's easy to understand for everyone who's using it as well.
yeah. So now if you want, sometimes what happens is these jars when you connect oxygen, no? So these do not deliver oxygen and there will be a lot of leaks. So if you have a problem there, what you need to do is you remove this jar and you connect the oxygen directly to the
Because you don't need the water bubble, you're already going through the humidifier.
yes, you can connect directly so to the inlet. So thereby it becomes easier for you to titrate the oxygen.
That's a
So
useful
otherwise,
tip to do it.
sometimes the pressures are not high, so it will be lost in the tubing. So you can do this.
Right.
And
Okay.
we have used it during resuscitation. So you can see here how long the TP circuit is. When you use with resuscitation, you have the TPs which has a manometer at the patient end. It's a long tube you can see here from there till the device. So
This is
you can actually
designed by
do
you as well, or it's a Mark, I mean, another device?
no same one. So you can use as a TPs, isn't it?
So you have
So
the PEEP valve.
without the humidifier, if you connect the same thing now, when you're using TPs, you have to use 10 liters flow. So the tube is connected. This is a TP circuit.
Yeah.
You can see it now.
So you have
The
a
machine.
PEEP valve at the end of it, yeah?
Yeah, you have a PIP and PEEP valve.
Oh,
So you have two valves here. So there is a PIP and PEEP valve.
okay, both.
So that is a PEEP valve and this one is a PIP valve.
And it comes
So
with the machine when they buy it. This is reusable or
yeah, so
disposable?
you can buy the TPs along with the circuit. And these TPs are easily available. So when you're doing
Disposable.
resuscitation, you can actually see how much PNP and PEEP the baby is getting.
Yeah.
So what I'm doing is, this is the PAP valve. And obviously you can see how much pressure you're giving. And so you can see the PEEP. PEEP is this knob, the blue knob, and PAP is the gray knob. So you can titrate the PIP and PEEP, and you want to increase FiO2, background oxygen you have to increase.
Can this be sterilized and reused, or it's a single use?
No, the circuit has to be disposable. But you can make a circuit which is reusable, but you need to use.
But the valves are difficult to, I mean, probably
No,
disposable.
it fits in with everything. This is your standard input, oxygen input from the TPs.
Can you give an idea of the cost? I mean, it's a great, I mean, service to the country,
So
I think.
this would cost around, if you want only the TPs, it will cost about 1 lakh rupees. But if you're wanting with a humidifier, it will go up to 2 lakhs. Because humidifiers are again MR850, the Fission Packle or any other servo humidifiers. You can see a baby is being resuscitation being done with the TPs, and even in transport, it has 4 to 6 hours battery backup. So you can see one of my friends, Ashish, was using in transport.
Nice. Ashish Mehta.
Yeah, Ashish Mehta.
So this circuit for the labor room, how much does it cost?
Circuit costs about 2,000 rupees. But you need to use it only when the babies require a resuscitation.
Yes. So
it's like TP circuit.
At least for the premature babies, you can start using it. And
yeah, and this is a company which does the sale and marketing. So Electrogenic Innovations.
I mean, share it with me. I put it in the video info. Somebody had asked this question based on your RDS lecture as well. I think it's a great service because as we discussed, the ROP rates are something to worry about, and indiscriminate use of non-invasive ventilation without the blender. I mean, and this is giving a solution to give the pressure as well as blender, and the use in the labor room, it's really good. The cost part, obviously, I mean, we owe a responsibility to the families to give them the appropriate treatment. So some cost will be involved, but you have to find the better solution. And obviously, this is the start. I mean, you will keep improving on it, and obviously, as you sell more, probably you can get more options like alarms and things built in as well. And
Yeah.
so, I mean, it's congratulations on this, and I hope it helps more people to use the appropriate um, mode. And in terms of tips to the youngsters who are watching this, I mean, what advice would you give them before we close?
So I think, see, all of us have good talent, and if you're taking up neonatology, choose one area of specialization. So you will be doing all neonatology, but I think I chose CPAP as my mission
Yes,
and vision. So like that, we have a lot of people in our country, like Umesh doing a lot of work on nutrition, Naveen doing a lot of work on development.
yes,
So we chose our field. Although general neonatology we do, but yes, this is the area which we work. And once you work in an area, no, you start questioning. You start
innovating.
getting questions and you get answers and you get innovation from that. So that's my advice. And there's a lot of, this is a very young field. So I think we are only 20, 30 years young. So there's a lot of scope for improvement. We have many diseases where we need to conquer.
Yes.
NEC, PDA, BPD, so sepsis. I think you name it, you have problems. So people need to work on this and see how we can
I think
make
training your
them.
team along with you, right? I mean, all of us believe in teaching to improve. So teach everyone around you so that you keep improving, and you are a good example to follow in terms of keeping things simple when you teach. So
I think that's one very important thing that whatever we learn, we need to teach, and our life will be satisfied only when we ensure that apart from earning, we need to commit something to the society,
yeah,
and that society commit will come from some innovation or some teaching. So this should be a selfless teaching, and where it is something which should give you happiness. So
I
I
think
think that's why we enjoy this.
that's something we all get from our PGA training. I think giving
I
to the
think so.
society.
Jipmer too.
Yeah, Jipmer too.
Jipmer too. Yeah.
That's good. I'll
We were
send
lucky, I think, both of us to be from
in the
Jipmer
same.
and from
Yeah.
PGI. Yeah. Thank you.
Thank you, Srinivas. I'll stop.